The purpose of this short presentation is to outline the basics of record keeping in veterinary clinical practice to support their use for clinical research.
At the end of this presentation, you should be able to 1. List reasons for maintaining patient records, 2. List record-keeping standards, 3. Assess the integrity of real-life practice records, and 4. Identify limitations of practice records for research. There are several reasons why a veterinarian might maintain patient records. One of the main reasons is to adhere to legal requirements of the state or territory jurisdiction. These legal requirements are founded on the need to maintain patient care and safety, to provide evidence and transparency for clinical decision-making, to facilitate continuous monitoring of patient status, and to ensure effective communication across veterinary teams and stakeholders.
As such, there are several record-keeping standards that should be adhered to when constructing a clinical record. The standards can vary slightly depending on the jurisdiction, but there are some fundamentals that are consistent across all areas. In general, the maintenance of records should be contemporaneous and must be legible and sufficiently detailed to allow another veterinarian to continue treatment of the animal. All records should identify the date of entry, the patient, client, all practitioners involved, the author of the record, and the patient signaling. The details of the record will then loosely be categorised into collection of information, clinical reasoning, diagnostic and therapeutic procedures, and client communication and consent. Collection of information may include any relevant history and physical examination of the animal. The details required can vary, but a good rule of thumb is to include what was examined and any body systems that were not examined. Some stakeholders might allow for the use of acronyms such as NAD, no abnormalities detected, or within normal limits, WNL, in the absence of abnormalities to speed up the record-keeping process. But it's best practice to provide details of both normal and abnormal findings. The clinical reasoning component of the record involves summarising the problems identified during information collection and provides an assessment on those findings. A plan is then formulated based on this assessment. If necessary, the clinical record will also include details about the outcome of any diagnostic tests, procedures, or therapeutic interventions, and the clinical reasoning component of the record may then be changed as a result of the new findings. And lastly, ongoing client communication and informed consent should be thoroughly and accurately documented.
There are several templates that summarise the principles of record keeping and promote a standardised approach, some of which might be more relevant for use depending on the context, and they can be used interchangeably. The HEAP template is generally used during a primary presentation, whereas the SOAP template is appropriate to use as progress notes for hospitalised patients, ongoing treatment plans, or to provide a summary for referral to another veterinary practitioner. As you can see, they both incorporate important aspects of record keeping and fall under the category of a problem-oriented medical record. While these are the accepted standards within the veterinary industry, there is no one right way to record a clinical record. Veterinary practitioners might not have the luxury of following a problem-oriented medical record approach every time they work with a patient, and so there can be significant variability in clinical records between individuals. As such, it is important for you to evaluate whether a record is complete, factual, and reliable enough for another individual to be able to understand what has occurred. Some questions that might assist in scrutiny of practice records could include: is the record dated and time-stamped? Are there client and patient details including signalment? If using a research database such as VetCompass, this information might be captured outside of the clinical record or anonymised for confidentiality. Is there sufficient detail to avoid misinterpretation of information gathered and assessed? Consider whether the absence of information might change your perception of clinical events. Has the practitioner made an assessment on all problems identified in the record? Similarly, is the clinical reasoning of the practitioner reported in a transparent manner and relevant to the problems identified? Are the diagnostic test results, procedures, and medical interventions reported with complete information? Is there appropriate evidence of continuity of care following the initial presentation?
While clinical records are a useful tool for research, there are several limitations. Despite the existence of standardised approaches to maintaining clinical records, the variable nature of records might result in inconsistent use of acronyms, terms, phrases, or location of the information within the clinical record, which can influence the accuracy of coding and data collection. Incomplete or missing data can also impact alignment with case definitions and research criteria. This is particularly relevant for studies that seek to explore risk factors of disease and in some cases might result in an abandonment of the research project. For example, absence of information regarding patient home environment might impact the ability to assess risk factors for fluted in cats. Absence of evidence of continuity of care or lack of follow-up with patients might mean that reported disease outcomes are limited. This is particularly relevant for studies that seek to relate an intervention to clinical outcomes. Incomplete or absent clinical reasoning can also result in under- or over-interpretation of a condition, which could bias or restrict the study population. For example, a practitioner providing an assessment of hyperadrenocorticism based only on clinical presenting complaints and signs without considering other differentials or the need for testing. The details of a clinical record may, for many reasons, lack accuracy or misrepresent reality. For example, a practitioner might report on the outcomes of a right lateral abdominal radiograph when the actual view they performed was a left lateral. There is little that the researcher can do to address this limitation. Lastly, the use of client and patient data raise ethical and legal concerns that can compromise the ability to report or reproduce the data in other research projects. The extent of this limitation is dependent on relevant institutional ethics approval.
In summary, this short presentation has outlined the reasons for maintaining patient records and the standards that should be followed to ensure their integrity. Whilst they are a valuable tool, you should now have a good understanding of the limitations of practice records for use in a research environment. Thank you for your time and attention.